This conference will now be recorded.
I'd like to welcome you all, physically, digitally, and spiritually, to this OSP meeting of ours. Um, to start off, I'd like to call Hafiz Mobile to do the tilawat for us. Hafiz Mobile, please.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيتها النفس المطمئنة ارجعي إلى ربك راضية مرضية في عبادي وادخلي جنتي صدق الله العظيم.
Thank you, Hafiz. Next, I'd like to call upon Professor Muin Saab, President of OSP Lahore, to open the session first. Khalid Saab is here.
Assalamu alaikum, ladies and gentlemen. As Joint Secretary OSP Lahore branch, it is my proud privilege and honor to be with you in this academic session. And I will request you to call the speakers one by one, and we will be marking them. We have 3 judges. Thank you.
Thank you, sir. We have a series of interesting cases to present to you. And to start off, I'll call upon Dr. Asen to please come and present your case.
Assalamu alaikum. My name is Dr. Yasser Memu, and this is a case which I saw when I was at resident at LGH Lahore General Hospital. A 26-year-old female. She was a resident of Bahawalpur, presented in OPD with a mass in a right excentrated orbit for 4 years. She gave history of domestic trauma to her 8 years ago. A few months after trauma, she developed a swelling in her right orbit, for which she underwent CN in Bahawalpur. Swelling was recurrent, and she underwent another CN a year later, again at Bahawalpur. She had another recurrence after 2 years, which according to her led to the forward protrusion of right eye, decreased vision and opacification of cornea. An excimeration was performed, and the surgeon noted vascular lesion with vascular malformation. Now, this is the patient that presented to us at LGA. That is the post. The patient has an exaggerated socket, and there's a vascular tumor. A 525 centimeter mass was noted in the right orbit. There was a prominent subcutaneous vessels. No visible excoriation, discharge hemorrhage was present, and the transurination was negative. On palpation, mass was firm in consistency, well defined, adherent to the underlying orbit. Overlying skin was pinchable, and it was firm on retroculture. On auscultation, there was no bruit. We did CBC following investigation with the CBC, chest X-ray, LFTs, RFTs, that is for all the baseline inflammation profile, CT orbit, and the main investigation that was, as because it was recurrent vascular tumor in an extended socket, was to do a digital subtraction angiography to rule out the vascular component in the tumor. Now, this is a digital Now, this is the film, that is the digital section angiography, and this is the internal maxillary artery. The DSA shows a vascular malformation in the branches of the internal maxillary artery was noted. Now, another film shows a tumor plus or vascular malformation of the internal maxillary artery. Rest of the systemic workup was normal. Our differentials was a traumatic, it can be a traumatic atrial venous malformation, cavernous hemangioma, capillary hemangioma, or a soft tissue tumor of the orbit. As the lesion was vascular and there was a malformation of the internal maxillary artery, the plan was to chemically embolize the fetal vessel, that was the internal maxillary artery, in the case followed by the en-bloc surgical excision of the lesion. Patient was referred to the intervention neuroradiologist. Fetal vessel was embolized using NBCA, that is the N-butyl cyanoacrylate, as an embolizing agent. Now, this is the post-embolization here. As you can see, there is no tumor blush. The fetal vessels that was feeding the vessel has been embolized, and there is no tumor blush. There is another view, as the fetal vessel has been embolized. Post-embolization MRS shows no abnormal vasculature, as the fetal vessel has been embolized. After embolization, the fetal vessel surgery was planned, and en-bloc excision of the lesion was done, and specimen was sent for histopathology. Now, this is a post-op. Massive excised, there is a mechanical ptosis due to enophthalmos, and no active bleeding or discharge is seen on the second post-op day. That is we sent the specimen to the histopathology, and it shows a spindle type tumor, that is a subtype of a solitary fibrous tumor. That is a very rare tumor that is found in orbit. This is histopathology, and that is showing a spindle cell tumor of the, that is a subtype of the solitary fibrous tumor. Now, solitary fibrous tumors are rare spindle shaped neoplasias. These are benign orbital masses in middle-aged adults. Usually rises from the dermal dendrocytes or vascular pericytes, and they stain densely with CD34 or vimentin. SFP usually is the umbrella term that is used closely associated with the spindle-shaped orbital neoplasia that include hemangioparasitoma, giant cell angiofibroma, or a fibrohistiocytoma. So it is the umbrella term that is used for the following tumors. Subtyping into histological variants does not affect treatment modality, so we usually label them as a solitary fibrous tumor. They are more common in females. That risk factors are following trauma or radiation. So the risk factor was present in this case as the patient was having a domestic trauma 8 years ago, and it is a very high chance of recurrence if the tumor is not completely excised. That's a vascular tumor that can lead to recurrence, and this patient has 4 recurrences before the vessels was embolized. Clinical features: there's a painless proptosis, there's swelling, there's a palpable mass, and ptosis very rare. Most commonly found in the supremedial orbit, but can present anywhere in the orbit, including the lacrimal gland fossa. Knee compressed optic nerve, so visual acuity and optic nerve function should be assessed regularly. As it is a benign tumor, but there are chances of malignant transformation. And whether the risk factors for the malignant transformations are as follows. It's very rare that it can undergo malignant transformation, but it can undergo in some cases if it's a very long-standing cases. Recurrent cases after incomplete surgical excision or a radiotherapy has also been seen associated with the malignant transformation. Investigations: the main investigation is you have to do DSA, MRI, and definite diagnosis can only be done on the histopathology. Metastatic workup: as a tumor usually runs a benign course, so no metastatic workup is warranted unless signs of malignant transformation is there. Is very rarely metastasized to reverse, so metastatic workup is not required. Treatment: and block surgical excision is a treatment of choice given the tendency to recur, and malignant transformation is incompletely excised tumor. So our main goal is to completely excise the tumor margin, and high vascular tumor, so pre-op embolization may be warranted in selective cases. Chemotherapy has also proved to be beneficial, and radiotherapy should not be done in these cases as there is a high risk of malignant transformation. Routine follow-up should be done with incompletely excised tumor to note any recurrence, and patients with desert tumor should have a more vigorous follow-up and serial imaging. It has an excellent prognosis. 75% are benign and 25% shows aggressive inflammation. 70% of confirmed malignant tumor also shows no aggressive behavior. So it says 80 to 90% are benign tumor. Thank you. Somebody contact. नहीं तो उन्होंने लिखा है कि स्पिंडल सेल ट्यूमर है और इतनी क्लियर नहीं है सर इसकी नहीं तो डिफरेंशिएशन वाज नॉट पुअर, उसने कहा डिफरेंशिएशन गुड है। और बेसिकली सॉलिटरी फाइब्रस ट्यूमर्स की 3 सब टाइप्स हैं, जिसमें एक हेमेंजियोपेरासाइटोमा है, एक क्यूवेनस मेनिंजियोमा है। दीज आर वेस्कुलर ट्यूमर्स, जिसकी स्पिंडल सेल ट्यूमर अलग है, एक मैलिग्नेंट ट्यूमर है, मगर ये एक सॉलिटरी फाइब्रस ट्यूमर की सब टाइप का स्पिंडल सेल ट्यूमर है, जिसकी जो है डिफरेंशिएशन गुड है, उसमें कोई एनेप्लोइडी या मेटास्टेसिस या जो है एनसी रेशियो या तो नहीं टाइप है, बेनाइन टाइप की स्पिंडल सेल, या वो एक अलग एंटिटी है। ये दिस इज अ सॉलिटरी फाइब्रस ट्यूमर्स, ये अलग अम्ब्रेला टर्म है। ये है is a mirror term that is closely associated spindle cell nucleated hemangioparasitoma, giant cell angioperioma, and fibrous histiocytoma. These are there's a separate mirror term for these two. Then की fight that depends on अगर ये first rate है, first attack है, completely excised है, आपने कोई ट्यूमर नहीं है, तो इसकी malignant transformation is very rare, तो 5 year 80 to 90% survival rate है। मगर अगर आपने recurrent surgeries की हैं और आपने एनब्लॉक वैक्सीन अच्छी नहीं की, ट्यूमर मार्जिन छोड़े और malignant ट्रांसफॉर्मेशन हो गए, तो ये लोकली बहुत एग्रेसिव है, क्योंकि इसका मेटास्टेसिस रेयर होता है लिवर में। तो अगर इसकी malignant ट्रांसफॉर्मेशन हो गई है, दैट इज वेरी रेयर, तो उसका फिर 5 years जो है प्रोग्नोसिस वो 20 to 30% है। सर इसकी रेडियो नहीं कर सकते, क्योंकि रेडियो की वजह से नहीं कर सकते, दैट इज द रिस्क फैक्टर फॉर द malignant ट्रांसफॉर्मेशन। और कीमो वी हैव टू डू अ कीमो, अगर आपने इसकी डीएससी किया, डिजिटल सब्सट्रक्शन एंजियोग्राफी, और उसके ऊपर आपको ट्यूमर फ्लैश या कोई वेस्टर्न माल्फॉर्मेशन करें, हम जितनी मर्जी सीएन कर लें, द ट्यूमर विल रिअकर, सो वी हैव टू गो, वी हैव टू इंजेक्ट एनसीबीए इन द branches of the artery and we embolize it. Contact होता है, इंटरनल एक्सिलरी आर्टरी को we embolized it, उसके बाद उसकी जो फीडर वेसल कम हुई, तो उसकी ग्रोथ भी कम हुई, तो एक्सपीरियंस आसान हो गई। आई द पेशेंट प्रेजेंटेड अस, पहले भावलपुर में इसकी 2-3 दफा हमारे पास एक्सेंट्रेटेड सॉकेट में रिकरेंट मैस था। इट वाज अ मैस इन नॉर्मल लाइपॉड। 8 साल पहले इसको डोमेस्टिक ट्रॉमा हुआ था, वहाँ उसको मैच करते रहे, फिर उन्होंने इसकी एक्सेंट्रेशन की, फिर ये रिकर हुआ, फिर दूसरी दफा रिकर हुआ, फिर उन्होंने हमारे पास रजिस्ट्रेशन किया।
The first point is that Dr. Asser is FCPS qualified, so we include him in consultants, and he is not included in the training. So he is out of the competition.
Yes, sir.
He can go, मैं for second card आप उसको से कोई आप now all the vascular malformations are done AV malformation. अगर आप अमेरिकन अकेडमी ऑफ ऑप्थेल्मोलॉजी का भी नया एडिशन पढ़े, तो उसमें ये जितनी टर्म थी पहले केवर्नस हीमेंजियोमा और जितने ओमास थे, वो सब उन्होंने वेरिसीज और ये चीजें, तो AV malformations may be of no flow, low flow, or high flow. So this is the latest concept. For cavernous hemangioma है, तो every malformation having cavernous vessels. So label change हो गया. So very interesting case, excellent management. ये किसने किया था एम्बोलाइजेशन?
एम्बोलाइजेशन की थी उमैर रशीद साहब ने, हमारे पास एलकेएच में न्यूरो इंटरवेंशन रेडियोलॉजी का यूनिट है, एंड सर्जरी की थी प्रोफेसर मोइन।
वेल डन, एक्सेलेंट, गुड केयर। आज ये इसको थोड़ा सा इलैबोरेट कर दें, व्हाट इज डिजिटल सब्सट्रैक्शन एंजियोग्राफी?
सर डिजिटल सब्सट्रैक्शन एंजियोग्राफी में हम सिर्फ जो सारे सॉफ्ट टिश्यू स्ट्रक्चर्स हैं उसको सब्ट्रैक्ट कर देते हैं इमेजेस से, साथ में हमें सिर्फ वेस्कुलर स्ट्रक्चर्स नजर आए, ठीक है। तो अगर हम कोई वेस्कुलर मैल्फॉर्मेशन वी आर ट्राइंग टू है, तो जैसे एमआरआई में T1 T2 इमेजेस होते हैं टू लोकेट स्पेसिफिक पैथोलॉजी, तो डिजिटल सब्सट्रैक्शन एंजियोग्राफी में हम सारे सॉफ्ट टिश्यू जो है सिग्नल्स which is subtracted, and we only try to see the vascular structures so that any pathology that is related to the vascular structures can easily be appreciated.
आपने सीटी स्कैन एमआरआई पहले करवाया ना?
नहीं सर, क्योंकि वो सारा होके आया हुआ था हमारे पास, हुआ हुआ था, तो भी हमें करवाने का दोबारा क्या फायदा था? वी वर
किसको किससे सब्ट्रैक्ट करते हैं?
सर सॉफ्ट टिश्यू जो सिग्नल्स होते हैं किसी भी मेराइन में उसको सब्ट्रैक्ट कर देते हैं ताकि सर हमारे वेस्कुलर सिग्नल्स आए.
There was this angiography.
जिससे सब्ट्रैक्शन एंजियोग्राफी.
Angiography,
Yes.
angiography हुई ना.
जी सर.
There's protection किस चीज की?
हाँ.
की बात है. पहले आप एक स्कैन करते हैं जिसमें उस सारे को कर लेते हैं स्कैन. उसके बाद उसको एंजियोग्राफी की.
जी सर.
उसका भी स्कैन करें.
जी.
तो कंप्यूटर जो है जो पहला स्कैन और दूसरे में से निकालता है. इसलिए वेसल जो है वो ज्यादा प्रोमिनेंटली हो गया. वैसे भी एंजियोग्राफी किया लेकिन उसके ऊपर बाकी टिश्यूज का इफेक्ट होगा. कंप्यूटर क्या करता है कि पहले जो इमेज था पहला स्कैन था वो दूसरे स्कैन में से नॉट सॉफ्ट टिश्यू. आपने देखा बोन भी कोई नहीं.
बॉन्ड भी.
इसलिए मैं कह रहा हूँ कि बहुत सारी चीजें हम रूटीन करते रहते हैं. हमें पता नहीं होता ये क्या है. जस्ट कीप गोइंग लाइक दैट. यहाँ पे इस तरह होता है. तो पहले आपने इमेज लिया उसके बाद आपने उसकी एंजियोग्राफी की. अब उसका एंजियोग्राफी का भी पेज उसमें ऐड हो गया ना. तो कंप्यूटर को पता है कि पहला इमेज क्या है. उसने उसको निकाल दिया. दूसरा इमेज बहुत क्लियर नजर आ गया. इज नॉट ओवर शेडोड.
इंटेलिजेंट बहुत ज्यादा एकेडमिकली से काफी सारी बनी याद. तो आपने केस में मुगल में काम किया तो काफी सारी. तो मेरे इसमें क्वेश्चन थे आपने साइनो एक्टिवेट ग्लू इस्तेमाल किया है सेम एज एलपी टाइप की थी.
जी सर.
लेकिन ये मेडिकल ग्रेड है.
मेडिकल ग्रेड.
उसको वहां पे आप इंटरनल वैक्सीन में कैसे लेके गए और उसके बाद उससे फर्क क्या पड़ा करने ट्यूमर को क्या हुआ.
तो जैसे हमारे पास होता है कि कीमो एम्बोलाइजेशन होती है टू रिड्यूस द ट्यूमर. एक तो ट्यूमर का फ्लो रिड्यूस होता है, उसकी वेस्कुलरिटी रिड्यूस होती है, उसकी सर्जरी भी आसान होती है और उसका मास भी श्रिंक करता है. और
इससे श्रिंक तो नहीं होगा.
नहीं, उससे वो एम्बोलाइज हो जाएगा ना. उसका जो फीडर वेसल है वो उसका ल्यूमन कोलैप्स कर जाएगा. जब उसका ल्यूमन कोलैप्स कर जाएगा तो उसको जो फीड कर रहा है वो वेसल को उसको जो फ्लो है वो नहीं जाएगा.
तो बेसिकली इसमें यही होता है कि ब्लू विथ कई बार रेजर की तरह काम करती है कि अंदर जाके इट सॉर्ट ऑफ कोट्स द इनसाइड. जिस तरह समझ लीजिए कि एलपी का आपने एक बॉल बनाया है वो ट्यूमर के अंदर एक बॉल
ल्यूमन कोलैप्स हो जाती है.
तो फिर जब डिसेक्शन करते हैं तो उसमें से
ब्लीड कम हो गया.
एज अ सॉलिड ट्यूमर के तौर पे निकल आता है. दैट इज व्हाट इट इज.
इंटरेस्टिंग किया था वो फोटोग्राफ दिखाई. दो तीन जो छोटे से पॉइंट्स हैं उनका हाईलाइट करना है. ये बहुत जबरदस्त है और मैनेजमेंट बहुत अच्छी है. एक बात है कि प्रोसेस आफ्टर इनिशिएशन तो एनोफिल मॉस में जो ड्रिप नीचे आती है उसको हम
सूडोडोसिस का
नॉर्मल अल्कोहल हो और ड्रिप नीचे आए तो उसको
डोसिस.
दूसरा एन ब्लॉक एक्सचेंज पूरी रिमूव कर. अब ये पेशेंट आपके पास आता है तो आप प्रोसीड कैसे करेंगे. हाउ विल यू इन्वेस्टिगेट द केस. ठीक है. इसकी डिफरेंशियल डायग्नोसिस का है. So differential diagnosis should come before investigations because in the light of differential diagnosis you ask for investigation. और investigations के बाद आप एक criminal diagnosis पे पहुंचते हैं. तो ये हमारा नॉर्मल वो होता है. तो ट्रॉमेटिक AVM, ट्रिमेनस इमेजियोमा ये डिफरेंशियल डायग्नोसिस है. मेरा क्वेश्चन है कि इसमें एक्सेस क्यों नहीं शामिल.
As a patient was afebrile and
वो एक्सेस कोल्ड
access
नहीं होता.
if you
So फर्स्ट कनेक्शन भी हो सकता
must
है. और मतलब डिफरेंशियल डायग्नोसिस में आपने लियन को देख के अपने जेन में आपकी चीजें वो जिसमें जो आप फाइन नीडल एस्पिरेशन बायोप्सी करते हैं जहाँ आपको कंफ्यूजन हो वहाँ आप बहुत बड़ी सी नीडल जो देवी कैनुला की होती है वो इसमें डालें. अगर सिस्ट है तो वो पार आ जाएगा. अगर एक्सेस है तो पास पार आ जाएगी. अगर इवेंटियम है तो ब्लड आना शुरू हो जाएगी, तो आपको अंदाजा हो सकता है। नेक्स्टली जो नॉन इन्वेसिव टेक्निक्स हैं लाइक सीटी और एमआरआई, वो हम पहले करा, उससे अंदाजा हो जाता है। और अगर उससे नहीं हो रहा तो फिर नेक्स्ट स्टेप हम इन्वेसिव इन्वेस्टिगेशन। अब ये जो वेस्कुलर ट्यूमर है उसके लिए डॉक्टर भी बड़ा वो आपको बताता है कितना हाई फ्लो है इसमें। तो ये एम्बोलाइजेशन में डिफरेंट टेक्निक से करते हैं, कॉइन एम्बोलाइजेशन भी होती है।
तो कॉइन एम्बोलाइजेशन तो अक्सर वो हम जो है थर्ड ट्रेनर की जो पाइका आर्टरी है प्रोसीजर जो है उसमें कॉइन एम्बोलाइजेशन निकालते नहीं, हाँ निकालते नहीं है, साइज नहीं करते।
इसमें हमें ये पता चल जाता कि एम्बोलाइजेशन करने से मैथ कितना कम हुआ है ये।
हाँ
और एक फोटोग्राफ वो हो जाती कि जी एम्बोलाइजेशन के बाद कितना मैथ है, और दूसरी पे फोटोग्राफ ये होती कि एक्सीडेंट तो हमने ये डिसाइड करना है कि कितना वेस्कुलर कंपोनेंट था जिसको एम्बोलाइजेशन। फर्स्ट एम्बोलाइजेशन नहीं, आप लोग पेरिफेरी मेलैया में बैठा हुआ बंदा और वहाँ इंटरवेंशनल रेडियोलॉजिस्ट नहीं है तो उसको सर्जरी करनी पड़ेगी। तो उसके लिए भी इंडियन में होना चाहिए। और स्क्लेरोजिंग एजेंट्स जो है उनको अगर हम इंजेक्ट करते हैं तो कितना वेस्कुलर ट्यूमर रिग्रेस करता है। अब जैसे लिम्फेटिक एंजियोमा जिसको हम कहते हैं उसमें भी वो अच्छी इंजेक्ट तो वो वेस्कुलर ट्यूमर की रिग्रेशन लिम्फेटिक। सो ये भी एक ऑप्शन है। तो वेल डन, एक्सीलेंट, थैंक यू
थैंक यू सर।
Thank you, Dr. Hassan, for that very interesting presentation. Next, I'd like to call upon Dr. Zainab to please come and present your case.
Assalamu alaikum. I'm Dr. Zainab Tar, PGI in Ophthalmology Department here in Gulab Devi Teaching Hospital. My patient was a 31-year-old male resident of Lahore, referred from pulmonology ward to IOPD with a complaint of decreased vision for distance and near objects over the past 1.5 months. Dimness of vision was progressive, bilateral, and asymmetrical in pattern. He had been diagnosed with pulmonary TB and placed on ATT. He was taking ATT for the past 5 months. On general physical examination, he was a pale-looking, malnourished male, sitting comfortably, well-oriented in time, place, and person. On systemic examination, he had bronchial breathing with bronchi, CVS, GIT, and central nervous system were normal. On ocular examination, his visual acuity was 6/60 in right eye and 6/36 in left eye. No improvement on pinhole examination. Color vision was 0/24 bilaterally. Pupillary reflex was round, regular, and sluggish bilaterally, and there was no painful extraocular movements. On slit lamp microscope examination, bilateral interior segments were normal. IOP was 14 in right eye and 13 in left eye. Fundoscopy showed CD ratio of 0.2 bilaterally with healthy macula. All baseline investigations were done with serum B12, chest X-ray, CT scan head and neck, visual fields, OCT, and MRI brain. This is the picture of right fundus and left fundus, which were both normal. This is the picture of right visual field and left visual fields, which shows reduced retinal sensitivity in the temporal fields of both eyes, indicating chiasmopathy. This is the picture of the right and left OCT, optic nerve head, and retinal nerve fiber layer, showing normal parameters. The CT scan was normal. MRI head and orbits were normal. The diagnosis we made was ethambutol-induced optic neuropathy. We referred him back to the pulmonology ward to stop ethambutol immediately, started tablet methicobal 1 daily, and we called him for follow-up after 1 month. After 1 month, his visual acuity improved to 6/36 in right eye and 6/18 partially in left eye. There was no improvement on pinhole examination. Color vision improved to 1/24 bilaterally, and RAPD was negative. After 3 months follow-up, his visual acuity further improved to 6/12 and 6/9 partially. No improvement on pinhole examination. Color vision improved to 6/24 tiles in right eye and 5/24 tiles in left eye. RAPD was negative. After 6 months, his visual acuity was normal, 6/6 bilaterally, and the color vision improved further to 18/24 in right eye and 15/24 in left eye. RAPD was negative. This is the picture of the visual fields right and left eye after 6 months, which showed significant improvement in both eyes. Now he is on monthly follow-up. Literature review. The toxicity of ethambutol is proportional to the dose of ethambutol. It is observed in 15% of the patients receiving 50 milligram per kg per day, in 5% of patients receiving 25 milligram per kg per day, and less than 1% of patients receiving daily dose of 15 milligram per kg per day. Studies showed that some of the ethambutol-induced vision impairments are irreversible, example, visual field defects and sensitivity deterioration. Researchers have shown that the most common presentation of ethambutol-induced optic neuropathy is secocentral visual field defects, but in some severe cases, bitemporal amblyopia was also reported, which may have resulted due to the involvement of optic chiasma. In another research, the incidence of color vision abnormalities among patients undergoing DOTS was 47.88% after the average of 39.66 days on quadruple anti-TB therapy. The color vision abnormalities returned to normal within an average of 37.85 days after the discontinuation of ethambutol. The recommendations are to diagnose a case of ethambutol-induced optic neuropathy in its early stages, and initial eye workup should be done before we start the ATT, including visual acuity and color vision. And the patient should be on monthly follow-up with an ophthalmologist. Thank you. So in research, they've written the color vision goes down first and then the visual acuity. So that's why we want to keep the patient on follow-up so that we can diagnose it. So the color vision, normally we are using a Ishara chart, which is easy and affordable and easily accessible. So we counsel the patient कि अगर ये issue है तो आप फौरन आए. कलर अगर आपको कलर विजन में कोई इशू आए और कलर में कोई डिफरेंशिएशन में प्रॉब्लम आए, ब्लू ब्लैक, तो कलर की पहचान में अगर आपको तशखीस में मुश्किल हो तो
कौन सा कलर रोज देखता है, कौन सा कलर रोज देखता है,
सारे
आजकल तो बहुत आसान हो गया. क्या वो कंप्लेन करता है घर में, टेलीविजन को किसने छेड़ा, आज टेलीविजन को किसने छेड़ा, वेल डॉक्यूमेंटेड, उसको एग्जैक्टली पता है कि इसकी क्या कलर है, उसकी क्या यूज है, उसकी सैचुरेशन से सब पता है. तो दैट इज मोस्टली दिस इज द काम थोड़ा सा हमारे दोनों आंखों में डिफरेंस आप उसको कहते हैं कि देखते हो, क्योंकि एक ऐसा नहीं होता दोनों.
राइट सर.
तो अगर तुम्हें किसी दिन भी दोनों आंखों में फर्क लगे तो आप उसको महीने के बाद कोई वजह नहीं क्या है, फंडस में आपको कुछ नजर नहीं आया, क्यों?
तो फंडस नॉर्मल था बिकॉज ऑप्टिक न्यूरोपैथी हो रही है, पीछे फंडस के इफेक्ट आया तो फंडस पे भी कोई वो पिक्चर नहीं आई. सर जो हमारा केस है इसमें ऑप्टिक आजमा भी इन्वॉल्व था, ऑप्टिक नर्व में सब.
The aim of these presentations is to prepare the trainees for presentations on the international forum. हमने ऐसी presentation देनी है जो आप international level पे भी दे सकते. तो a few points जो आप थोड़ा consider करें. पहली बात ये है कि जो इसका टॉपिक है, टाइटल है, वो कोई कैसी बनाए. इस तरह उदाहरण साहब बैठे हुए हैं, एक मेजर टॉपिक होता है we care where the others don't care. मुझे याद आ रही है 1990 में there is यार कोई नहीं मालूम, ठीक है। तो वन सिलेक्शन ऑफ टाइटल। दूसरी बात ये है कि ये आप पिछली स्लाइड पैराग्राफ लिखे हुए, पहली स्लाइड से शुरू करें। नंबर 1 स्लाइड आपकी कौन सी है? ऑलवेज मेक इट इन बुलेट्स, पॉइंट्स 1 2 3 4। ये जो पैराग्राफ है तो पढ़ना बड़ा मुश्किल है। और सारी स्लाइडें ऐसी हैं जिनमें पूरा पूरा पैराग्राफ है, तो इसके भी फॉर्मेट तरीके नहीं चलते। दूसरी बात की आपने हिस्ट्री प्रेजेंट किया, उसके बाद जनरल फिजिकल एग्जामिनेशन will provide a diagnosis where differential diagnosis. Then examination लाइफ में आप differential diagnosis, उसके बाद investigation should be in the line of examination। ये नहीं है कि जो आपके डिपार्टमेंट में इन्वेस्टिगेशन है वो सारी करा रहे हैं, आपके अस्पताल में जितनी इन्वेस्टिगेशन शुड बी टारगेटेड। आप एक इन्वेस्टिगेशन कराते हैं, ब्लड सीटी क्यों करा रहे हैं? ये नहीं है कोई ये सब नहीं कराते। पीएसआर करवाने में क्यों करते हैं? इसकी ऑलवेज क्लियर लॉजिक फॉर एवरी इन्वेस्टिगेशन दैट यू ऑर्डर। और लॉजिक उसको बताएगी जब आप इन द लाइन ऑफ एग्जामिनेशन आप प्रोसीड करें। यदि मेरा ये तो these are the investigations। अगर आप अच्छे हॉस्पिटल में बैठे हैं और इतने सैकड़ों पेशेंट को यहाँ पे एंटी टीबी चल रही होगी, तो आपके पास लोग आते हैं टीबी एंटी टीबी ट्रीटमेंट शुरू करने से पहले?
नहीं सर, करंटली नहीं
आते। जब मैं जॉब कर रहा था हमारे डिपार्टमेंट में रूटीन मेडिकल वार्ड का जो पेशेंट एंटी टीबी पे तो पहले वो हमारे पास आएगा, हम उसकी कलर लीजिए। और बड़ा सिंपल सा तरीका, इतना सा पेपर होता है हमारे पास, 3 स्ट्राइप पे रेड ग्रीन और 3 कलर। तो पेशेंट पूछते ये कौन सा कलर है, ये कौन सा, 1 सेकंड। तो कलर ग्रीन को हम एंटीटीवी एक कलर एंड कलर लाइन बाद में आपके पास आया, आप कहेंगे जी ये तो वो करते हैं आप। लेकिन तो हमारी एज मेडिकल प्रोफेशनल एक जिम्मेदारी है एडवोकेसी। एडवोकेसी क्या है कि हम जो समझते हैं कि पेशेंट क्या पब्लिक क्या बेहतर है उस पर लोगों को देखिए। तो मेडिकल डिपार्टमेंट हेड के पास जाके रिक्वेस्ट करेंगे कि ये आपने अपनी प्रिंसिपल के पास जाए, एमएस के पास जाए, ये डायबिटिक रेटिनोपैथी स्कीम के लिए ये प्रोटोकॉल बनाए हैं, तो ट्राई तो करें। तो सिर्फ मरीज को ट्रीट करना हमारी जिम्मेदारी नहीं है, ये एसओपी बनाना हॉस्पिटल की, और ये कोशिश ये भी हमारे पास की गैर आज चीज में हम कामयाब नहीं होते। बहुत सारी जगह है जहाँ हम खड़ी है, लेकिन हमें कोशिश जरूर करनी चाहिए कि जी आप अगर भी चेक करें या आपने हमारे पास लेकिन दिस शुड बी अ मस्ट फॉर प्रिवेंटेबल है। आप डोज कम करेंगे कंट्रोल की तो लड़की ठीक हो जाएगी, जितना उसको डैमेज हो रहा है और सिग्नल को सही हो जाएगा। तो मतलब मैं इसकी भी अपनी कोशिश करती हूँ। और आई वुड सजेस्ट कि आप जो फैक्टर उसको थोड़ा सा आपने इन्वेस्टिगेशन बड़ी अच्छी कराई है, ये जो इन्होंने इन्वेस्टिगेशन रखी है इसका फायदा है। जब भी आप केस प्रेजेंटेशन करेंगे, पब्लिकेशन करेंगे, ये प्रूफ जरूरी है। अब इन्होंने ओसीडी कराई और कौन सी इन्वेस्टिगेशन?
सर विजुअल फील्ड्स हैं, ओसीटी, सीटी, एमआरआई,
फंडस फोटोग्राफ कराई आपकी। तो अगर आप ये चीजें सेव नहीं करते हैं तो आप अपने स्टेप पे जाते हैं। पहले आया
नहीं सर, नॉर्मल फटस
ये रिवर्सिबल ब्लाइंडनेस है, इसकी रिवर्सिबल ब्लाइंडनेस
सर, रिवर्सिबल है, इम्प्रूव हो रही है सर। हो सकती है, एज इज अ फैक्टर So irreversible हो सकती है, age is a factor in that. More than 60 years अगर patient के हो, say older than 60 years, तो 1 in 5 of the patient जो है वो irreversible होती है, reversible होती है. तो होती है irreversible भी depending on other factors. जैसे age में एक factor बता रही हूँ जिसमें more than जी improve हो जाए.
इनिशियली तो रिवर्सिबल है लेकिन बाद में बहुत डिलेड हो सकता है तो फिर और तो एंटी ट्यूबरकुलोसिस मेडिकेशन है जो कि विजन ड्रॉप करती है.
सर जो रिसर्चेस में मैंने पढ़ा है वो यही कि थैम्पिटॉल जो है वो कर दिया. जी जी ठीक. थैंक यू सर.
Actually, from
आपके बाकी जगह हमारी देखिए हम मरीज ब्लाइंड कर रहे होते हैं. मैं कि डॉक्टर है उसकी मां है वो ब्लाइंड होगी मुझे नहीं पता लगा वो प्रॉब्लम किधर से चली गई. देन शी हैज वो बंदा हमारे पेशेंट की कंप्लायंस है वो समझते थे गॉड गिवन चाहे कुछ भी नहीं हो रहा है वैसे ही थोड़ा बहुत तो गार्ड है वो लेट है उसको अप्रोच देते हैं और उसको इतना सीरियसली देते ही नहीं. और जब तक वो जाती है समझते हैं कैटरेक्ट आ रहा है कुछ और आ रहा है वो मैच टाइम जाता है ये तो अच्छी रिकवर होगी लेकिन कहीं तो बिल्कुल भी रिकवर नहीं.
Yeah, thank you, Dr. Zainab. Next, I'd like to call upon Dr. Porras. Please come and give your presentation.
Assalamu alaikum. My name is Dr. Porras Ahmed. I'm a postgraduate trainee in MCPS program in Gulab Devi Hospital. My case is about a 28 years old obese female presented in OPD on 21st of June 2021 with complaint of severe headache, diplopia, vertigo, and blurred vision for the past 4 months. She had been diagnosed with hypertension 1 year ago and her blood pressure remained persistently high despite treatment. Her BP check was 145 by 90 millimeters of mercury. For the last 2 weeks, she started experiencing severe headache and vomiting. Patient told that she is also having difficulty crossing the road. Her general physical examination, her weight was 95 kg, height 162 centimeters, BMI 36.2, blood pressure 138 by 90 millimeters of mercury. Ocular examination showed visual acuity in right eye to be 6 by 24, left eye 6 by 36, no improvement bilaterally. Color vision 13 by 24 in right eye, 10 by 24 in left. Pupillary reactions in right eye was sluggish and in left eye RAPD was positive. Extraocular movement was full in all gazes bilaterally. Confrontation test showed constriction of visual fields bilaterally. Anterior segment was normal bilaterally. IOP in right eye 16 and left 18. Fundus examination showed grade 3 papilloedema bilaterally. Our differential diagnoses were chronic migraine headache, chronic tension type headache, benign intracranial hypertension, new daily persistent headache NDPH, and hemicrania continua. Management investigations were MRI and MRV, OCT, retinal nerve fiber layer, and visual fields. MRI findings were widening of bilateral perioptic nerve sheaths, the flattening of bilateral optic nerve head suggesting papilledema. Impression on MRI were suggestive of benign intracranial hypertension. MRV impression were partially empty sella, no intracranial mass, no dural venous thrombosis, edema in optic nerve sheath bilaterally. These findings are suggestive of pseudotumor cerebri. OCT retinal nerve fiber layer showed fundus picture showed papilledema bilaterally. Visual fields. Multiple points of decreased retinal sensitivity were noted in both eyes. Our probable diagnosis was benign intracranial hypertension. After confirmation of benign intracranial hypertension, patient was referred to neurology for expert opinion. They planned and performed diagnostic lumbar puncture. Opening CSF pressure was 60 centimeters of water, whereas normal is of 17 to 18 centimeters, 7 to 18 centimeters of water. CSF cytology was within normal limits. Medical management was started by neurology department. Patient was started on IV corticosteroids, tablet, acetazolamide, 250 milligram QID, and NSAIDs. Follow-up. Patient came for follow-up examination after 2 weeks. Headache and vomiting was settled, but further decrease in visual acuity. These were her stats after 2 weeks follow-up. Visual acuity in right eye was 6/36 and left eye was reduced to counting fingers. Color vision in right eye was 10/24 and there was nothing in left eye. Visual field showed further constriction of visual fields bilaterally. IOP was 18 bilaterally, and fundus examination was grade 3 papilledema on both sides. After this, we planned surgical management. Due to severe or progressive visual loss and failure of medical therapy, it was planned optic nerve sheath fenestration, ONSF, and the patient was referred to Dr. XYZ for surgical management. Post-op follow-up was after 10 days, and these were our examination. Visual acuity was 6/18 partially in right eye and 6/36 in left eye, which showed improvement. Color vision in right eye was 20/24 and in left eye was 18/24. Confrontation test showed improvement bilaterally. IOP was 14 bilaterally. And fundus examination, we had grade 1 papilledema bilaterally again. Okay. OCT RNFL improved in parameters of optic nerve health and retinal nerve fiber layer. Second one was OCT macula, again showing improvement. Visual field, again it showed improvement of retinal sensitivity at multiple points in both eyes. Patient was called for follow-up after 6 months. She was much satisfied with her improvement in visual acuity, and she was able to perform her daily activities. These were her stats after 6 months. Visual acuity was 6/9 partial in right eye, 6/18 in left eye. Color vision was 24/24 bilaterally. Visual field showed significant improvement. IOP remained 14, and fundus examination showed slight disc pallor. All these tests after 6 months of follow-up showed significant improvement in the patient. Literature overview. Idiopathic intracranial hypertension, sometimes called by its older name, benign intracranial hypertension or pseudotumor cerebri. It is characterized by an increased intracranial pressure in the absence of a tumor or other diseases. The main symptoms are headache, nausea, vomiting, as well as pulsatile tinnitus, double vision, and visual symptoms. If untreated, it may lead to vision loss due to associated swelling of optic disc in the eye. Right. Most cases occur in young women who are obese and less frequently in men who are otherwise healthy patients. Patients with high body mass index and recent weight gain are at an increased risk for this disorder. Systemic diseases, disruption of cerebral venous flow, certain endocrine or metabolic disorders, and exposure to or withdrawal from certain exogenous substances are associated risk factors that must be ruled out if idiopathic intracranial hypertension persists in a patient who is not overweight. Right, management. Weight reduction. Drug treatment includes acetazolamide, furosemide, and topiramate. Surgery options are of optic nerve sheath fenestration. Right, indications for surgery. Severe vision loss due to elevated intracranial pressure causing papilledema. It can also result from other diseases such as pseudotumor cerebri syndrome, cerebral venous sinus thrombosis, and intracranial tumors causing intracranial pressure elevation from decreased cerebrospinal fluid outflow. Contraindications of surgery. It should not be performed on a patient on chronic anticoagulation due to risk of bleeding into the orbit. It should typically be avoided in patients with CNS infection due to potential for seeding of the orbit with the infectious organism, in mild or moderate vision loss related to ICP elevation, in management of headache in patients with pseudotumor cerebri syndrome and patients with intracranial pressure elevation without optic disc edema or vision loss. Complications of surgery: complete vision loss, 1 to 2% chances, damage to posterior ciliary arteries, retrobulbar hemorrhage, optic nerve sheath, cystosis, strabismus, and ciliary ganglion injury. Diagnosis. For diagnosis, we use Dandy's criteria, which when introduced in 1937 was sign and symptoms of increased intracranial pressure and CSF pressure more than 25 centimeters of water. No localizing signs except for abducent nerve palsy, normal CSF composition, normal to small slit ventricles on imaging with no intracranial mass. It has been further modified to symptoms of raised intracranial pressure, headache, nausea, vomiting, transient visual obscurations, or papilledema. No localizing signs except for abducent nerve palsy. Patient awake and alert. Normal CT, MRI finding without evidence of thrombosis. Lumbar puncture opening pressure of more than 25 centimeters of water and normal biochemical and cytological CSF composition. No other explanation for raised intracranial pressure. Advancements in surgery are CSF diversion. It includes lumboperitoneal shunts and also ventriculoperitoneal shunts and dural venous sinus stenting. Thank you. Sir, when the patient presented to us in OPD, in the first slide, I have stated that the patient said that she had trouble crossing the road, which meant that she had peripheral vision loss. Yes, sir.
Start off with paracentral scotoma rather than a central scotoma. So why is it used to be called benign intracranial hypertension? What was benign in this?
So benign is false.
नाम से ही जरा benign intracranial hypertension. तो benign क्यों कहते थे? Yeah, was it a tumor? Supposed to be a tumor in the brain or क्या था?
No, sir, pseudotumor cerebri इसका
अब idiopathic intracranial hypertension. Pseudotumor था. लेकिन वजह क्या थी? What does it cause any body systemic loss, long-term damage करती है इसमें नहीं. इस चीज को damage करती है.
Sir, visual loss इसमें.
सिर्फ the only thing it does is benign इसी में से कहते थे कि pressure brain का ज्यादा है जो कि ट्यूमर में होता है, जो कि स्पेस ऑक्यूपाइंग रीजन में होता है, लेकिन इसमें ऐसे जो चीज निकलती नहीं थी और दूसरा बॉडी में वो लॉन्ग टर्म डैमेज करती नहीं है. ये सवाई इसके के ऑप्टिक नर्व को अफेक्ट करती है. इज इट अ सेल्फ लिमिटिंग डिजीज? अगर हो गया तो सारी उम्र चलती रहेगी अगर एडमिनिस्ट्रेशन ना की तो.
So it is self-limiting, but
self-limiting अगर एसिटाजोलामाइड कितनी देर टाइम में ठीक हो जाएगा?
सर इसका उस पे जो उसके प्रेजेंटिंग सिम्टम्स है उस पे डिपेंड करता है. एसिटाजोलामाइड सर अगर पेशेंट को कोई विजन लॉस, नो विजुअल लॉस हो पेशेंट में, तो एसिटाजोलामाइड राउंड अबाउट मैक्सिमम इसकी आप डोज दे सकते हैं 1 ग्राम. अगर विजन लॉस के साथ प्रेजेंट हो तो मैक्सिमम 2 ग्राम तक डोज दी जा सकती है पेशेंट में. तो अकॉर्डिंग टू द सिम्टम्स सर फिर पेशेंट को ट्रीटमेंट स्टार्ट करते हैं. अगर पेशेंट थेरेपी से, मेडिकल थेरेपी से इंप्रूव कर रहा है तो एसिटाजोलामाइड को टैपर ऑफ कर देते हैं. Yes, sir. Yes, sir.
It takes at least 2-3 years before it burns itself out.
Yes, sir.
तो जितनी देर वो बर्न आउट नहीं होती तो उसको देते रहते हैं ट्रीटमेंट ताकि वो मॉनिटर इसको विजुअल फील्ड से करेंगे. दैट गिव्स यू एन आइडिया. ओसीटी में इशू आता है. ओसीटी में ऑप्टिक नर्व के इसमें एडिमा भी है और ऑप्टिक नर्व एट्रोफी भी हो रही है. दोनों चीजें क्रॉनिक जब एडिमा में जाता है.
Yes,
तो इस वजह से इसमें ओसीटी में ऑप्टिक नर्व की थिकनेस आती है. वो कई बार आपको फॉल्स इमेज दे रही होती है. एट्रोफी हुई होती है लेकिन थिकनिंग की वजह से एट्रोफी की जो सिग्नल है वो नहीं आ रहे होते. तो आपको रेड जोन में नहीं जाता, वो नॉर्मल आ रहा होता है. हालांकि एट्रोफी शुरू हो चुकी होती है. क्योंकि वो जब जब वो उसकी पेपरिडीमा खत्म होता है, स्वेलिंग खत्म होती है, तो फिर एकदम नीचे आता है, तो वो इसमें से आता है बिकॉज वो आइटरी पहले शुरू होगी, जो अब एडिमा खत्म हुआ तो मोर अपेरेंट आ
Yes.
इट इज अ सेल्फ लिमिटेड डिजीज, लेकिन जिस तरह वो वेट रिडक्शन है, आपको सॉल्ट रिस्ट्रिक्शन है, और इसके अंदर बेसिक का नॉर्मल ये अगर दे दे तो ठीक है, लेकिन कई लोग सिम्टम्स ऑफ प्रोग्रेसिव विजुअल लॉस, इंडेक्स उनको फिर ऑप्टिकल शीट रेस्ट्रिक्शन के नंबरों में रिकमेंडेशन चेक में आप
Yes. Thank you, sir.
डिजीज की अर्ली स्टेजेस में क्या फाइंडिंग है और लेट स्टेजेस में क्या फाइंडिंग, दोनों का हमें पता होना चाहिए। सो अर्ली केसेस में the only finding is swelling of the optic disc and enlargement of the blind spot. You speak कराएंगे कोई भी फील्ड इफेक्ट नहीं आएगा, पिपल का रिएक्शन नॉर्मल है, सिर्फ ये जो ब्लाइंड स्पॉट है वो एनलार्ज 1.5 मिलीमीटर। सो अगर आपको उसकी आफ्टर डिफेक्ट आ रहा है या फिर ऑप्टिक नर्व फंक्शन डिस्टर्ब हुआ है, तो आप दूसरी चीजें कंसीडर करें। ऑप्टिक न्यूराइटिस तो नहीं है, एटीएसटी ऑप्टिक न्यूरोपैथी तो नहीं है, लेकिन हाइपरटेंशन, पेशेंट हाइपरटेंशन का है, इसके एडिमा मेलिग्नेंट हाइपरटेंशन की वजह से तो नहीं है। तो ये चीजें डिफरेंशियल डायग्नोसिस में आप कंसीडर जब डिजीज बहुत ज्यादा प्रोग्रेस करने लगती है, फिर ऑप्टिक नर्व को डैमेज होता है। ये ओसीपी ओसीपी में क्या फाइंडिंग आती है फैसिलिटी में, और कुछ रेटिनल ग्लास फाइबर टेक्निक होती है, तो कलर कौन सा चेंज होता है, ये ओसीपी में सारी
सर उधर चलो।
तो हम देखने के आदि होते हैं ना कि ग्लोकोमा में जो ग्रीन कलर होता है वो रेड हो जाता है, येलो होता है, इसके ऑपोजिट है। नेचुरल फाइबर की जब थिकनिंग होती है तो ग्रीन कलर व्हाइट हो जाता है। ये अगर आप देखें तो ये बहुत सारे व्हाइट है, तो हमें क्योंकि ऐसे ब्रांड कॉमन होते हैं, इतनी जल्दी हम पिक नहीं करते। ये वाइट वाइट का मतलब है कि ये जो ग्रीन जोन है इससे ऊपर चला गया, तो ग्रीन से ऊपर वाइट। तो ये जो डिजिट्स में लिखा हुआ है रेटिनल नर्व फाइबर की थिकनेस ब्लॉक आर्म में और क्वाड्रेंट्स में, ये भी याद होनी चाहिए ताकि उसको कंपेयर कर सकें। लेकिन ये कलर इंडेक्स अब इसका फायदा भी ये होता है कि आप देख सकते हैं ट्रीटमेंट के साथ ये जो वापस ग्रीन की तरफ आ रहे थे, जो रेटिनल थिकनेस कम हो रही है, तो इसका डायग्नोस्टिक भी है और प्रोग्नोस्टिक भी है। तो ऑब्वियस प्यूपिली इफेक्ट जो है ना, प्यूपिली रिएक्शन वो बहुत जरूरी है। आज ये हाइपरटेंशन में जो वैसे इंट्राक्रेनियल हाइपरटेंशन में ये प्यूपिली लाइट रिफ्लेक्स अफेक्ट होगा कि नहीं?
यस सर।
ये आपका जो टॉपिक है रेडियोपैथिक
यस सर।
इंट्राक्रेनियल हाइपरटेंशन, इसमें प्यूपिली रिएक्शन लाइट फ्लो करेंगे, आपको अफेक्ट होगा कि नहीं होगा?
नो सर।
आफ्टर प्यूपिली डिफेक्ट होगा?
यस सर।
आफ्टर प्यूपिली डिफेक्ट एपीडी,
यस सर।
उस केस में होगा कि नहीं होगा? मैं मुझे पूछ रहा हूँ होना चाहिए कि नहीं होना चाहिए?
यस सर, होना चाहिए।
नहीं होना चाहिए।
केस में मेट्रिक होगा तो फिर हो सकता है।
यस सर।
क्या होता है? ये एडिमा जो होता है, जिसमें एडिमा, इस चीज में एडिमा,
यस सर।
क्या चीज जो है स्वेल कर जाती है जिसमें, जिसकी वजह से पेपर एडिमा होता है? Any idea? Swelling of the axons, और अगर axons डैमेज हो जाए, कम हो जाए, इस तरह कॉम्प्लिकेट करके तो उसमें फैसिलिटी मानी होगी। There is nothing to swell. बने का हाथ में क्या हाथ की swelling के लिए, ठीक है बेटे?
Thank you, sir.
Thank you, Dr. Pars. Next, I'd like to call upon Dr. Usman. Please come present your case.
Bismillahirrahmanirrahim. I'm Dr. Usman Shabir, working in ophthalmology department, Gulab Devi Hospital. Today presenting a case of sudden deterioration of vision, unilateral vision. And my patient is 48 years, female house lady, resident of Lahore, presenting in IUPD with a complaint of sudden blurring of vision in the left eye from last 1 week. Decreased vision is associated with dull pain in the left eyeball and severe headache, but there is no history of vomiting, trauma, and no such previous episodes. Patient was using glasses for her near vision, and the rest of the ocular history was unremarkable. Her past medical history shows that reveals that she has pain in small joints of hands and wrist, and no history of diabetes, mellitus, hypertension, or asthma. Patient was married with no child and non-smoker. In his drug history, she was taking some medications for her joint pains, which was advised by her physician. It contains tablet alprazolam, duloxetine, and piroxicam, NSAID. Her family history was unremarkable. General physical examination was within normal limit. And in systemic examination, the musculoskeletal system, there is the tense, swollen small joints of hands and wrist, but there is no visible deformity of hands. Rest of the examination normal. In ophthalmic examination, her visual acuity in the left eye is hand movement, which didn't improve with pinhole and best corrected visual with reflection and pinhole. Her pupils RAPD was positive, and her IOP in the left eye was 18 mmHg as compared to the right, which is 14 mmHg. Our posterior fundus examination shows the papular edema with blurring of the disc margins and chorioretinal folds and exudative retinal detachment. सर ये chorioretinal folds हैं और ये exudative retinal detachment. Our initial first differential diagnosis was neuroretinitis, optic neuritis, choroidal mass, orbital inflammatory disease or mass. Our urgent B scan was ordered, was carried out, which shows the choroidal and scleral thickening with obliteration of the disc area due to the thickening of the sclera, and subtenon, there is also a subtenon fluid in the B scan. Excuse me. Actually, क्यों ये वो इस पर अब उधर और चल रहा है क्या प्रॉब्लम है?
ये सर जो प्रेजेंट था और ये नेक्स्ट यहाँ पे नेक्स्ट आई ठीक.
Porosity macula of the left eye also shows the fluid beneath the neurosensory retina. And further investigation was carried out, which are all investigations are within normal limits except RF factor and her ESR. RF factor was positive, which is range 32, and ESR was 45. So our final diagnosis was posterior scleritis of the left eye. And treatment was initiated with topical NSAIDs, tablet delta cortical 1 milligram per kg, and capsule omeprazole, and patient was referred to rheumatologist for opinion and further follow-up. On follow-up visits, weekly follow-up visits, patient vision was improved from hand movement to 624 to 66 partial. Pupil RAPD was resolved, and fundus examination, disc swelling, exudative retinal detachment, and parietal folds all were resolved, completely resolved. Day 1 picture shows the day 1 and day 5, 2 weeks. And now the literature review. There are three pre-equatorial vascular layers that covering the eyeball: conjunctival vessels, superficial episcleral plexus, and deep vascular plexus. In episcleritis, maximal congestion, there is involvement of the episcleral vessels, and in scleritis, there is the maximal congestion of the deep vascular plexus. We can differentiate with the 2.5% phenylephrine, which cause congestion of the conjunctival vessels, and 10% phenylephrine causes the congestion of the episcleral vessels. Classification of the scleritis: it is the anterior and the posterior scleritis. Anterior is further classified into diffuse, nodular, necrotizing, and non-necrotizing. Posterior scleritis is inflammation of the sclera behind the recti muscle insertion, and it's a potentially blinding condition. The presenting age was is between 40 to 60 years. Common in women, bilateral 35% cases associated, most commonly associated with rheumatoid arthritis. Posterior scleritis can present with pain, decreased vision, restricted motility, and can be associated with interior scleritis in 40% of the cases. Posterior scleritis signs include exudative RD, choroidal folds, uveal effusion, disc edema, myositis, and proptosis. Systemic association: mostly 50% of the cases of scleritis are associated with systemic diseases, in which mostly are rheumatoid arthritis, and most common association common in female. And if the anti-CCP antibodies is positive, then there is an increased risk of ocular involvement. In rheumatoid arthritis patient, if anti-CCP antibodies are positive, then there is an increased risk of ocular involvement. And these are the hands deformity. Other associations are vaginal granulomatosis, relapsing polychondritis, polyarthritis nodosa, and tuberculosis. Investigation are carried out to rule out the cause of scleritis. That includes autoimmune profile, chest X-ray, syphilis, Montauk's, urinary acids, and serum waste levels. Ocular investigation most common is the B scan. B scan shows a characteristic T sign. The stem of the T is made by the optic nerve, and the crossbar is made by the fluid containing space. And if these findings are not obvious, then we can do the CT scan, which also shows the scleral thickening. In treatment, first line the topical and oral NSAIDs, second line systemic or local prednisolone, third line is steroid sparing immunosuppressive, and fourth line is biological blockers. A study published in Ocular Immunology Inflammation Journal 2016 is concluded that 71% were women, 62.3% cases are idiopathic, 40% of the cases are associated with systemic disease, and 12.2% cases are associated with rheumatoid arthritis. Relapses may occur in around 1 in 3 patients. And other study was published in Retina Journal 2016, which concluded that nodular posterior scleritis should be considered in the differential diagnosis of a single amelanotic choroidal mass showing high internal reflectivity on B scan. It might be a posterior scleritis, nodular posterior scleritis. Posterior scleritis is a potentially blinding condition, so the timely diagnosis and the intense treatment are vital when restoring the eye. Thank you.
So, I would appreciate his slides and his presentation, selection of topics, and so this is an ideal presentation. This is a presentation that can be made on any international forum. Anything on the paragraph you speak, very slide. So first to last slide, कहीं पे इन्होंने 8-10 लाइनों का सब्जेक्ट बुलेट्स नेक्स्ट 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 2-3-4 points. This is the way to present and prepare a presentation. और तो आखिर में जाए तो और जो मुझे सबसे अच्छी चीज लगी है वो ये है कि जो लिस्टेड और उसका रेफरेंस. This is the scientific way of publication and presentation. ये केस स्टडी अगर अपने दो तीन एक केस लोए थे तो बैठे लेकिन हर जगह पे आप देखें 2-3 लाइनें हैं बस 2-3-4 वर्ड्स हैं एक लाइन. एक्सीलेंट.
थैंक यू सर. थैंक यू सर. हमने जो इनिशियली इसको ट्रीटमेंट इसमें फर्स्ट लाइन जो ट्रीटमेंट है एक्चुअली सर आप उसमें ओरल एनसेड से स्टार्ट करते हैं, लेकिन हमारे पास जो पेशेंट प्रेजेंट हुआ था वो ऑलरेडी ओरल एनसेड्स ले रहा था, उसके बावजूद उसको पोस्टीरियर स्क्लेराइटिस था. सो वी स्टार्टेड जंप ऑन सेकंड लाइन ओरल प्रेडनिसोलोन 1 मिलीग्राम पर केजी से हमने उसको स्टार्ट किया एंड अल्हम्दुलिल्लाह सर वो उसी से ही वहाँ पे प्रेजेंट हो गया. अदरवाइज स्टडीज ये कहती है कि अगर पेशेंट 3 माह तक जो है वो रिस्पॉन्ड नहीं कर रहा तो आप उसको बायोलॉजिकल ब्लॉकर्स इम्यूनोमॉड्यूलेटरी थेरेपी पे लेके जाएंगे. और सर इम्यूनोमॉड्यूलेशन में सर एडेलिमैब एंड रिटुक्सीमैब ये दो में बेसिकली यूज हो रही हैं. इसमें जो है सर रिटुक्सीमैब जो है उसकी 12.5 मिलीग्राम आईवी डोज है 0 वीक 2 वीक्स 4 वीक्स एंड 6 वीक्स पे. एंड जो एडेलिमैब है सर वो 0.5 मिलीग्राम सब कट आपने वंस इन अ वीक देनी है. तो ये इसकी इम्यूनोमॉड्यूलेटरी थेरेपीज हैं सर. कुछ इंडिकेशंस हैं जिसमें नेक्रोटाइजिंग एंटीरियर स्क्लेराइटिस अगर है तो उसमें आप इनिशियली जल्दी इम्यूनोमॉड्यूलेशन से स्टार्ट कर सकते हैं बिकॉज वीडियो लॉस वाज सो रैपिड कि आपको उसमें फिर टाइम जो है ना वो नहीं इतना गेन करने का टाइम मिलता. तो सर उसमें वो इम्यूनोसप्रेशन में मिथोट्रेक्सेट दे सकते हैं एंड मिथोट्रेक्सेट की डोज जो है सर वो हम 10 mg से स्टार्ट करते हैं orally and then it's according to the response हम इसको 2 mg kg के हिसाब से पर वीक इनहांस कर सकते हैं. मैक्सिमम डोज जो होगी वो 25 मिलीग्राम इसकी जो मिथोट्रेक्सेट की हो. उसके अलावा साइक्लोफॉस्फेमाइड और साइक्लोस्पोरिन भी यूज कर सकते हैं. थैंक यू सर. जी सर ओसीटी एक अब कुछ एक सीरियल नहीं करवाया सर. एक ही ओसीटी था जिसमें शुरू में ओसीटी वो सब रेटिनल फ्लूइड जो है ना उसपे शो किया था. मैं
यहाँ पे ओसीटी नहीं है तो
जी सर.
डिफिकल्ट टू मैनेज क्या आपने और से करवाएं.
जी सर. हम
इसमें ये अप्रिशिएट के ये मुश्किल काम है अगर आपने
सर मोस्टली हम एलजीएच यहाँ से रेफर कर देते हैं. करीब भी है और हमें या मेरा पेरेंट इंस्टीट्यूट भी है तो मुझे सपोर्ट भी काफी रहती है वहाँ से डॉक्टर्स की.
तो वो इन्वेस्टिगेशन के रिजल्ट ये आपको डॉक्यूमेंट करने में आसानी होती है. पहले ये था आपकी ट्रीटमेंट से ये हो गया फोटोग्राफ्स इन्वेस्टिगेशन का रिकॉर्ड ये आपने अब तो हर मोबाइल में कैमरा है तस्वीर उठा रहे हैं और पेशेंट को बाद में रूम भी करते हैं आपके पास रिकॉर्ड. मेरे पास मतलब कम से कम 8-10 हज़ार फोटोग्राफ होंगी मेरे पेशेंट्स की और इन्वेस्टिगेशन. मैंने बुक लिखी थी तो वो एक मेरे पास मटीरियल है. तो आपके पास जिस तरह आप अपनी फैमिली की और अपनी सर्जरियां संभाल के रखते हैं ना बना के एल्बम्स उसी तरह पेशेंट की एल्बम बनाए और अपने हर डिजीज वाइज कोर्स और काउंसलर की सिलेक्ट करें। ठीक है, ये बहुत जरूरी है। इसके बगैर ना आपकी पब्लिकेशन होगी, ना आगे आप प्रेजेंटेशन में आपको। तो ये मोबाइल का जमाना है, अभी आप फोटो
Ji, thank you, Dr. Usman. Now we're very lucky to have Dr. Ahmed Salam from the USA. He's a consultant ophthalmologist, Arkansas. He'll give us a video presentation live. Thank you.
Hi, it's my pleasure to be with you here and to present in this meeting. And thank you so much for the kind. Hi, it's my pleasure to be with you here and to present in this meeting. And thank you so much for the kind invitation. Special thanks to my friend Dr. Kaka. So, fungal endophilitis is an endogenous infection. It's the most common cause of endogenous infection. Most commonly caused by Candida. Different species from Candida is Candida albicans, Clavibacter cruzi. Most important is albicans, and also there's aspergillus, and there are other different types of organisms. Risk factors. We're all aware of risk factors of endogenous endophilitis. But I want you to think about it like there need to be a source of getting the fungal inside the body. Maybe the patient would be immunosuppressed, maybe not like intravenous drug use. Can a patient who's immunosuppressed only without any recent history of intravenous drug use, or indwelling catheters, surgery, contract fungal infection? We've seen this very rarely. Probably there's a source of getting the fungal infection inside the body that is missed. Regarding the pathophysiology, it comes from the choroid into the retina. In those sections, the histopathology on the left and the microsection on the right shows it very nicely as it buds into inside the eye from the choroid, where it's flat region, raised choroidal lesion, then
Let me show you
into the
some
retina
pictures
and then
here
into the
regarding the
vitreous.
causes of fungal infection. The key chamber can be mild inflammation. Sometimes
Let me show you some pictures here regarding the cause of fungal infection. The antechamber can be mild inflammation, sometimes it's severe.
This is an early case here of fungal infection. You can see in the color picture there's a very small lesion. You can see more of the autofluorescence. You can see as well areas of blood as well because of systemic effect of the Candida infection. But you can see clearly the bacterial lesion, which is really budding from the choroid inside the retina very nicely.
Clearly, the
On the
bacterial
OCT scan
from the choroid inside the retina very
here you
nicely.
can see the fungal lesion into the retina and budding inside, especially the picture on the right side. You can see the string of hairs here, or the cotton ball-like lesion on the left side. And similarly, you can see a fungating lesion or budding lesions. String pearls
And similarly, here you can
the
see a
budding lesion,
fungating
very, very
lesion, budding
suggestive.
lesion under this. String pearls and
This is the picture of the previous patient as inflammation settled down. You can see the lesion becoming more consolidated.
This is the picture of the previous patient as
You can
inflammation
see an
settles
inferior
down.
lesion,
You can see the
which was
lesion
not seen
becoming more
before.
consolidated.
And
You
that's
can see
after
the
treatment
vitreous
with
surface.
systemic and
You can see an
intravitreal
inferior lesion
treatment.
which was not seen before. And that's
There's a
after
different patient
treatment with
who
systemic
had
and
renal
intravitreal
surgery,
treatment.
then decreased vision, and
There's a
developing
different
lesion.
patient who
Here
had
after starting
renal
treatment,
surgery,
become
then
consolidated. And you can see
decreased
one of
vision,
them
then he got
on the
these
left side,
lesions, and
body
here after
inside
starting treatment,
the
the
vitreous
lesions
cavity.
become consolidating. I can see one of them on the left side budding inside the vitreous
That's the
cavity.
same patient we discussed in the last slide. And the other right, you can see the lesions are healing and getting
That's the same patient we
vascular
discussed in the last slide.
vascularization
And the
and
other eye, you
scarring
can see the
around.
lesions are
They can
healing
become
and
so
getting
vascular
vascular
that
vascularization and
actually you
scarring
can use
around
an
them.
anti-VEGF
They can
before
become
check
so
to
vascular
manage the vascularity.
that
Because of the enhanced vascularity of
actually
the
you use
lesions,
an
can go
anti-VEGF
on to
before the
develop
treatment.
traction
You
of
didn't
the
manage the vascularity.
And this is the
Because of
appearance of
enhanced
traction of
vascularity of
the
the lesions,
for
you
the
can go
fundus.
on to develop tractional retinal
So
detachment.
this is a nice
And
table
this is
which
the appearance
answers
of
an important
tractional
question
retinal detachment
differently.
following
Fungal
fungal
and
infection.
bacteria, endogenous
So this is
endophthalmitis,
a nice table
and
which
fungus is
answers an
more
important
granular.
question difference
If you
between
also have
fungal and
raised
bacteria
lesions and budding
endogenous
lesions,
endophthalmitis
choroid mass
and
is
the
more
fungal
like
is
a
more
fungal
gradual.
infection.
If you also
while
have
in the string
raised
of
lesions
those
and
like
budding lesions
bacterial
with a choroidal
infection,
mass,
usually
that
have
look
more
like a
diffuse
fungal
and
infection,
subretinal
while
abscess
in the string of
is more
pores
common
where
with bacterial
bacterial
infection
infection,
as compared
you
to
have more
fungal
diffuse
infection.
and subretinal abscess
So
is
diagnosis,
more
so
common
first
with
it's a
bacterial
diagnosis of
infection as
suspicion
compared to
and
fungal
clinical
infection.
diagnosis. You want to support that.
So
You
diagnosis,
culture
first it's a
the
diagnosis of
organism from blood
suspicion,
and
and
urine.
clinical diagnosis, you want to support that.
Tab
If
or
you
vitreous tab
culture
or
the
tractability
organism from
with
blood or
vitreous
from
tab. In
urine, you
that
can also
paper
do
here
a
quoted,
deep-chamber tap
he said it
with
showed
vitreous tap
90%.
or
Fuse rates in
vitrectomy
the range of
with
60%.
vitreous tap. In that
PCR
paper here
been
quoted,
tried to
he said
improve
showed
the
90%,
success,
but use
the
rates in the range of
results really
60%.
are
PCR
not very good.
been
Now
trying to
that that's
improve
called
the success,
2D,
but the
which
results
can be
really
done on blood and
are not
vitreous,
very good.
and it
Now
seems
there's
to
a
be
test
getting
called 2D,
more
which can
response
be
and a
done on
higher.
blood and vitreous, and it seems to be getting
As for the
more
treatment, I'd like you to remember
response and a
systemic
higher
treatment, very
yield.
important. Voriconazole or fluconazole, much better
As for
than
the treatment, I would like you to remember
If the
systemic
lesions are
treatment,
flat
very
and the
important.
alveolar, that's more than
Voriconazole or
3
fluconazole, much better than
or you're getting
anthracycline.
endophthalmitis,
If the
that
lesions
you
are
have
flat in the outer
intravitreal
choroid, that's more
treatment.
than enough. If the lesions are
Voriconazole
raised
is much better
or you're getting endophthalmitis,
more
then you need
expensive
now to add
and
intravitreal
has
treatment.
more
Voriconazole is much better than
Anthracycline still
anthracycline,
can work for
but more
intravitreal
expensive
injection.
and has more broad spectrum.
And there's a nice
Anthracycline still
slide
can
that
work for
shows
intravitreal
the
injection.
susceptibility for anthracycline and fluconazole.
There's a nice slide
And we
that
find that
shows
fluconazole is better
the
than
susceptibility for
and
anthracycline,
voriconazole is the
fluconazole,
best.
and
But like
voriconazole.
it's more
And you find
expensive
that
and it's more
fluconazole is
toxic
better than
as compared
anthracycline,
to
and
fluconazole, particularly
voriconazole
on
is
the
the best. But drug is more
As
expensive
for
and is more
intravitreal treatment,
toxic
again, same
as
thing was
compared to
shown.
fluconazole, particularly on
Voriconazole
the
is
lip.
more
As for intravitreal treatment, again, same thing
has,
was
has
shown,
more
but
wide
voriconazole
spectrum.
is more
An important question here, what about the role of the treatment?
has
The
more
role of
wide
the treatment
spectrum
for
of
management
cover.
of constipations
An
is very
important
well
question here, what
established.
about the role
There's
of
no doubt that this
vitrectomy?
is very
The
helpful.
role of
For
vitrectomy for
example,
management of
vitreous
complications
opacities of
is very well
treatment,
established, and there is no doubt that this is very helpful. For example, persistent vitreous
the
opacity
question
after
is,
treatment
does
with
vitrectomy
retinal
improve
membrane,
vision?
retinal
So you can do
detachment,
vitrectomy
whether
for
it's traction or
pocket,
rheumatologist.
look
But the
for my
question is,
skirt on,
does
does that
vitrectomy
lead to
improve the
visual
vision? So if you do
improvement?
vitrectomy
Two
for cases
studies,
of
one of
fungal
them we did, another
endophthalmitis
study
early
from
on,
direct
does
test
that
showed
lead to
actually there's no
visual
difference in
improvement?
the final
Two studies,
visual
one of them we did, and another study
visual
from
tract
Direct Tab that showed actually
However,
there's
we
no
found that
difference in the
actually
final
increases the risk of
visual
retinal
acuity
detachment.
if you do
The problem
vitrectomy
is
or
it's
not.
a difficult
However, we
surgery,
found that actually it
and sometimes
decreases the risk of
those
retinal
patients
detachment later on.
are very
The
sick
problem is
with
it's a
vitrectomy
difficult
before,
surgery,
so it's good to know what's the role
and
of
sometimes
vitrectomy.
those patients
Personally, I
are
treat the
very
patient
sick to do vitrectomy
systemic and
for, so it's
intravitreal
good to know
treatment,
what's the role of
and then
vitrectomy for
vitrectomy
vision.
later on.
Personally, I treat the patient
But this
with
is a case of presumed
systemic and
fungal
intravitreal treatment
endophthalmitis
if
in a
needed,
patient
and then
with
vitrectomy
history of
later on
intravenous
if fungal
patient was
needed.
treated
This
with
is a case
systemic
of presumed fungal endophthalmitis in a patient
vitreous
with
tap
history of intravenous
biopsy
drug.
in
The patient was treated with
The
systemic and
patient
intravitreal
responded to treatment
voriconazole,
with some
and a
degree of
vitreous
vicious
tap
phase from
biopsy
plus
came back as
to
negative. The patient
3 plus.
responded to treatment with some
But
decrease in the
left
vitreous
to
haze
there is
from 4
macular
plus
pigmentary
to
infection on the
about 3
central
plus,
presumed
but he was
fungal
left
lesion.
also with macular
Vitrectomy
and
surgery was
peripapillary traction
indicated
from the central
to clear the vitreous
presumed
and
fungal
also to
lesion.
relieve the macular traction. We
Vitrectomy
are now
surgery
about
was
3 to 4
indicated
weeks post
to clear the
presentation
vitreous
and
opacity
initiation of
and
treatment.
also to
This
relieve
is
the
the
lesion.
antihistamine
We are now
adherence
about 3 to
at the
4
time
weeks
of vitrectomy.
post presentation and initiation of treatment. This is the antihistamine adherence at the time of vitrectomy.
Vitrectomy was started under to get a large vitreous biopsy that was sent for microbiology.
Vitrectomy was started under air to get a large vitreous biopsy that was sent for
Next,
microbiology.
infusion was switched to BSS and core vitrectomy was completed. The hyaloid was partially
Next,
separated.
infusion was switched to BSS and core
Hyaloid
vitrectomy was completed. The hyaloid was
Now
partially
attention was given
separated,
to
so it was
the
not
lesion,
difficult to
try to remove the
complete the
traction
hyaloid
of the nerve.
separation with the vitreous cutter. Now attention is given to the posterior pole lesion to try to remove the traction of the nerve.
The granuloma is connected to the peripapillary retina with thin membranes. So here I'm peeling these membranes
The
off.
granuloma is connected to the peripapillary retina with thin membranes. So here I'm peeling these membranes off to be able to reflect the lesion.
Now the lesion is getting loose and I'm peeling it off the optic nerve.
Now the lesion is getting loose and I'm peeling it off the optic nerve.
So lichen adherent diabetic membranes, and it's safe to peel over the optic nerve to initiate the dissection.
So lichen adherent diabetic membranes, it's safe to peel over the optic nerve to initiate the dissection, but once you go over the retina, you need to cut and delaminate rather than peel. And the same applies here. So once I went over the retina, now I'm delaminating the lesion using a pair of 25G scissors. Here I'm performing a posterior capsulorhexis, starting with a slide forward blade and completing it with a pair of vitrata forceps to deliver the lesion through the anterior segment and out of the eye.
Now back to the posterior segment to grasp the lesion, bring it anteriorly through the capsulorhexis.
Now back to the posterior segment to grasp the lesion, bring it anteriorly through the capsulorhexis over the iris.
This is the histopathology of the
and then out of the eye.
Lots of inflammation and necrosis.
This is the histopathology of the lesion showing lots of inflammation and necrosis. With GMS stain, we could actually isolate candida lesions. And this is the appearance of the eye after surgery with 20/40 vision with a contact lens. Thank you so much for watching.
Hi, it's my pleasure to be with you here and to present.
I think it was a very good presentation on fungal endophthalmitis. This was probably endogenous endophthalmitis. We get endophthalmitis post cataract surgery is what we call IV drug, and we get fungal endophthalmitis as well. But the main problem which we get is post-operative fungal endophthalmitis, which is very difficult to treat, and it sort of sometimes ends up into patient going into crisis, and you might have to do evisceration for those. But the main thing is, if you pick it up early, especially doesn't show up on the first day or first week, it usually shows up later. If you pick it up early, you would start off with antifungal injection. As I said, voriconazole is a good alternative. But if you know that it is Canada, then obviously voriconazole is very effective. Otherwise, vitrectomy, as described, is very effective for this. But even after doing vitrectomy, it tends to produce retinal breaks. If it continues for a long period of time, you might end up having to use silicone oil, laser, and different things to control the patient from this.
Thank you, sir. Last but not the least, you have questions? Sorry. Last but not the least, I'd like to call upon Dr. Samra, AP Dermatology, Gulab Devi. Thank you, ma'am, first of all, for sitting through all our ophthalmology lectures. Please come and deliver your lecture. Thank you.
Ji, Assalamu alaikum. As Dr. Faisal has already told you, I am Dr. Samra, working as an assistant professor in Gulab Devi Hospital. Thank you, ophthalmology department, for inviting me as a speaker. So I will be briefly discussing bullous disorders related to eye. So the aim of this presentation is to give you people a brief know-how. How will you proceed further if you encounter a patient with a bullous disorder with eye involvement? So the main immunobullous disorders which are associated with cicatrizing conjunctivitis can be divided into intraepithelial and subepithelial disorders. The intraepithelial disorders include pemphigus vulgaris, vegetans, pemphigus foliaceus, and pemphigus erythematosus. Subepithelial disorders include bullous pemphigoid, mucous membrane pemphigoids, EBA, bullous LE, linear IgA disease, and dermatitis herpetiformis. This is the basics of the intraepithelial and subepidermal disorders. So if you can see, these are the 5 layers of the skin. In pemphigus vulgaris, you will see the blister here in the intraepithelial area. There will be atympholytic cells, and there will be intraepidermal blister here with tombstoning, right? In bullous pemphigoid, the blister will be here under the basement membrane, right? And you will find eosinophils within the epidermal cavity. And in dermatitis herpetiformis, the blister will be subepidermal, but here you will see papillary microabscesses along with inflammatory infiltrate, mostly neutrophils. So this will be the basic differentiation points. This is a very important and interesting slide if you can understand. So according to the layers of the skin, we will divide in different disorders, and accordingly there will be the clinical presentation. If the disorder is very superficial, subcorneal, there will be very flaccid blisters, and the patient will fall in the category of pemphigus foliaceus. And you will see very superficial blisters or erosions or crusting mostly in the upper areas of the trunk. It can occur in all ages. There will be redness, crusting, and the blisters will be few and fragile, right? And it can be drug-induced as well, like with D-penicillamines or captoprils, etc. Next is, we have already discussed intraepidermal blisters with IgG deposition, mostly seen in pemphigus. Here, mostly seen in the elderly with oral lesions and esophageal erosions. The blisters will be flaccid, will be present all over the body with erosions, and Nikolskin's sign will be positive. And sometimes it is associated with neoplasias. Next two, which are more of your interest, are cicatricial pemphigoid and bullous pemphigoid. Here the blister will be subepidermal here, and there will be a deposition of IgG and C3. In cicatricial pemphigoid, you will find only few lesions on the body, mostly on the upper trunk, mostly seen in the elderly with itch and the blisters and erosions in the oral cavity, eye, and in the GI as well. And in bullous pemphigoid, the lesions will be present all over the body, mostly in the elderly patient, mostly associated with underlying neoplasias, and the blisters will be small but tense. And in dermatitis herpetiformis, you will see very fine blisters, and it is in the form of micropapilla, mostly in the middle aged, and can be present all over the body, but mostly on the extensor surfaces. So what are the main differences between bullous pemphigoid and pemphigus vulgaris? It tends to affect the elderly, can affect any old age group. More antibodies are mostly seen against hemidesmosomal proteins, whereas in pemphigus vulgaris, most antibodies are found against desmoglins, mostly testoglin 3, but can be found against 1 as well. In bullous pemphigoid, tense subepidermal blisters will be formed. In pemphigus vulgaris, you will find the flaccid blisters. Our oral cavity is usually spared, but is involved in 50 to 70% of the patients. At dermoepidermal junction, IgG and C3 deposition. In pemphigus vulgaris, IgG will be present throughout the epidermis. Treatment is mostly oral steroids along with the underlying lymphoma or any other disorder you find. You have to treat that in bullous pemphigoid. In pemphigus vulgaris, oral steroids and immunosuppressants. These are the clinical images of the pemphigus vulgaris. Here you will see there is a large erosion and flaccid blisters on the arm and on the back of the patient with crusted erosions. And this is the involvement of the oral cavity. Oral cavity is more squarely involved as compared to the bullous pemphigoid. These are the lesions of bullous pemphigoid. Here you can appreciate there are tense blisters everywhere. There are few erosions, but most of them are tense blisters which tend to erode within 2 to 3 days. But in pemphigus vulgaris, most of the lesions tend to erode after 24 hours. This is again a slide of bullous pemphigoid erosions with small tense blisters. Involvement of the oral cavity, you will find few erosions inside the oral cavity too. Involvement of the gingiva and the palate as well. The most important, cicatricial pemphigoid. There is involvement of cicatrizing conjunctivitis, in which involves conjunctival inflammation with progressive scar. This is the commonest cause of progressive conjunctival cicatrization. And the classification, not always, but in most of the cases, the classification of cicatrizing conjunctivitis follows the dermatological classification of immunobullous disorders. The severity again varies from mild, moderate to severe, along with scarring or no scarring. And the therapeutic options are limited, as of course, depending upon the early diagnosis and the treatment. So disease may be present localized to one site or may affect any part of the body involving the mucous membranes. Ocular involvement alone can present in 18 to 50% of the patients in mucous membrane pemphigoid or cicatricial pemphigoid. And about 60% of the patients presenting to the dermatology clinic always have ocular involvement or conjunctival inflammation at the time of presentation. So it is very important. This is the brief classification of the conjunctival involvement according to the stage. Stage 1 is chronic conjunctivitis with subepithelial fibrosis, then shortening of the inferior cornix, symblepharon formation, and then the end stage ocular cicatricial pemphigoid. This is again the staging system, and these are the slides. I'm not going into the detail of these slides because you people can understand and describe it better than me. So I'm progressing to the skin side. And the complications, if there is ocular involvement, it can lead to fibrosis, destruction of the tear ducts, corneal ulceration, corneal pannus, and ultimately blindness. If there is laryngeal involvement, it can be severe, life-threatening stenosis, which can even require tracheostomy. If there will be involvement of the middle ear, deafness can occur, and sometimes carcinomas, mostly SCCs, have been reported from the chronic oral and esophageal ulcers. Next is the linear IgA disease, in which the patient can also present with some eye involvement. Linear IgA disease is the autoimmune blistering disorders, mostly occur in the infants and children. There will be tense blisters, vesicles in the annular formation. Crown of jewels, this is the hallmark of linear IgA disease. You can appreciate there is annular erythema, there is central erythema with annular blister formation. This is called crown of jewels. This is the clinical hallmark of linear IgA disease. Next is EBA. EBA is also a clinically heterogeneous subepidermal disorder. Antibodies are found against type 7 collagen, and it can affect between 44 to 54 years of age, and the clinical presentation will be skin fragility, erosions, blisters, and crust, mostly on the trauma-prone sites, mostly on the hands, knuckles, elbows, knees, and toes, which lead to scarring, alopecia, and nail loss. These are the clinical images. You can appreciate this is on the elbow and on the knuckles of the extensor surfaces of the patient. And here you can appreciate erosions on this patient. Bullous LE, another entity which can present either there is involvement or either the patient has LE alone, or with bullous LE, eye involvement can be a part of that. So blisters, erosions, most importantly on the sun exposed sites, but can appear anywhere on the body, and most of them heal without scarring. These are the clinical images of bullous SLE. You can appreciate this erythema on the shoulder of the patient with few small blisters, and similarly erythematous eczematous lesions on the arms of the patient. Next is dermatitis herpetiformis. It is a chronic, intensely pruritic skin condition which occurs mostly in the gluten-sensitive enteropathy, and it results from the deposition of IgA antitransglutaminase antibodies in the dermal papilla with neutrophil formation and neutrophil infiltration and blister formation. It is a very pruritic disorder, so very rarely you will find intact blisters. Most of the time we will find excoriated erosions or very small blisters on the extensors of a child. Here you can appreciate these are small intact blisters, but in clinical practice we have rarely seen it on the elbow of a child. Management on the broad spectrum, if any immunobullous disorder is suspected, we give immediately start oral steroids along with the immunosuppression once the diagnosis is made based upon the clinical scenario and histopathology. But from you people, management of mucous membrane pemphigoid is of more importance. So if there is only oral involvement, Then the first line would be professional oral hygiene with topical moderate to potent topical steroids. If no response, then we will proceed to dapsone or anti-inflammatory antibiotics like doxycycline, sulfapyridine, and sulfamethoxypyridine has some role. Along with that, minocycline or nicotinamide can be added because but most of these treatments are not available as a single line agent like nicotinamide in our setup. So we have to give in combination, and we are limited in the management of the patient. Third line is we can add prednisolone. If there is generalized mucous membrane pemphigoid without rapid progression to the conjunctiva, larynx, or esophagus, then we will start dapsone along with prednisolone. Second line would be mycophenolate mofetil with prednisolone, and third line treatment would be the same as for the rapid progression mucous membrane pemphigoid lesions. So if the patient presents with generalized mucous membrane pemphigoid with rapid progression, then the first line would be cyclophosphamide with prednisolone in a tapering dose. Second line would be mycophenolate mofetil, and the third line would be adsorption with rituximab or IVIGs. That's it from the skin department. Thank you. Any questions, suggestions? Please. Gigi, of course, there is a long list of bullous disorders, and there is a long list of disorders which are related to the eye. But our main focus was on the immunobullous disorders. That's why we have not included in that. Yes, it is short nowadays, but it is easily available. No, not nowadays. It is short nowadays, but in the past it was easily available. In my PG training, we used to give frequently dapsone to every person, especially in CBDC. It was the first line, but nowadays it is short. Nowadays, not at all. Sorry. सर लेप्रोसी के लिए भी हम बहुत ज़्यादा हुए हैं, क्योंकि हमारी जो दूसरी है रिफैम्पिसिन वो भी अलग से नहीं आ रही, तो हम बहुत उसमें है. लेकिन ऑफ कोर्स वी आर ट्रीटिंग, वी आर गिविंग ATT WHO के साथ कोलैबोरेशन से. ऑल्दो द मेन लेप्रोसी सेंटर इज इन द म्यो हॉस्पिटल, तो जो मेन उनका है फोकस वो वहीं पे होता है, वही उस पूरे को करते हैं. हम लोगों की रोटेशंस लगती हैं ड्यूरिंग द PG ट्रेनिंग वहाँ पे. लेकिन ये है कि आजकल ये दोनों चीज़ें शॉर्ट हैं, तो फिर हम ऑल्टरनेटिव्स पे ही जाते हैं. सर एक तो जो जितने भी ड्रग इरप्शंस हैं उसमें कि आई की इन्वॉल्व हो सकती है. इसके अलावा जितने भी जो हैं वो बुलस डिसऑर्डर्स के अलावा जितने भी वायरल इन्फेक्शंस हमारे पास आते हैं जिसमें जो है पेशेंट प्रेजेंट करता है, उसके साथ भी आई की इन्वॉल्वमेंट वेरी कॉमन. If we are specific to the bullous disorders, in any bullous disorder, our involvement can occur. Simple inflammation, conjunctival inflammation is very common, either with the disorder or with the as a side effect to the treatment. If we put the patient on the steroids or immunosuppressants, तो उसके साथ वायरल कंजक्टिवाइटिस, बैक्टीरियल कंजक्टिवाइटिस तो पेशेंट को बहुत कॉमन होता ही है, तो हमें बहुत कोलैबोरेट करना पड़ता है आई डिपार्टमेंट से. But to be specific to cicatricial pemphigoid, mucous membrane pemphigoid is the most common. जी सर. Fabry syndrome, yes, that is the congenital epidermolysis bullosa. That is the congenital form. सर उसमें जेनेटिक मैपिंग का रोल है, जो बाहर के मुल्क में उसके ऊपर बहुत ज़्यादा स्टडीज हो रही हैं जेनेटिक मैपिंग पे. और इसके अलावा जो है आर्टिफिशियल स्किन, बट नो स्पेसिफिक ट्रीटमेंट हैज बीन गिवन. ये जेनेटिक ब्लिस्टरिंग डिसऑर्डर है ना, उसको लॉक सिंड्रोम कहते हैं, लेरेंजियल ऑक्यूलोक्यूटेनियस इन्वॉल्वमेंट.
क्या पढ़ते हैं सिमिलर फ्रॉड की होती है और दोनों में कोई डिफरेंशिएटेड फीचर्स होते हैं.
सर ये तो आप लोग ज़्यादा देते हैं टाइम। सर हम लोगों को तो लगता है कि आई इन्वॉल्वमेंट इन द वेरीफाइड डिपार्टमेंट, तो आप लोग ज़्यादा बेहतर बता सकते हैं। थैंक यू सर।
Thank you, ma'am. And now we move on to the most anticipated part of the program, the prize giving certificate giving ceremony. Khalid Saab, please, on the stage. Thank you.
So thank you very much. I will invite Professor Muin Saab, President OSP Lahore, to come over. Sir, आप भी आ जाए, आप भी आ जाए। आ जाए सर, आपके हाथ से देना है, हमने दिलवाना है। So first of all, I will call Dr. Hassan. Dr. Hassan FCPS qualified है, इसलिए हमने इनको कंसल्टेंट्स में शामिल कर दिया है। नो मोर ट्रेनीज, वो आपकी कैटेगरी चेंज हो गई। तो तो डॉक्टर पोरस अभी थर्ड से शुरू करें। तो दोनों तो second prize goes to Dr. Porus. उस्मान, आपका भी FCPS क्लियर हो गया हुआ है? नहीं हुआ अभी? FCPS
मैं दोबारा
अच्छा, फिर करेक्शन आ गई है, तो ये पेन जो है ना वो आप डॉक्टर जैनब को दे दें। डॉक्टर जैनब
फर्स्ट, सेकंड,
तो थर्ड पोजीशन है डॉक्टर पोरस की, और डॉक्टर जैनब की सेकंड पोजीशन है, डॉक्टर उस्मान की फर्स्ट पोजीशन। तो डॉक्टर जैनब को पेन दें। और पेन है? नहीं, पेन चलो लाओ जी। And the first prize goes to Dr. इनकी प्रेजेंटेशन से ये लग रहा था कि बहुत सीनियर है, इसलिए हमेशा पढ़ गया था। डॉक्टर समरा प्लीज। ये थैंक यू वेरी मच डॉक्टर समरा फॉर अ वेरी इल्यूमिनेटिंग टॉक। और मुश्किल सा सब्जेक्ट था जो कि हमें काफी समझ आ गया। थैंक यू वेरी मच। अहमद सलाम साहब को सर्टिफिकेट हम ईमेल कर देंगे। और जसानी का कोई है रिप्रेजेंटेटिव? जसानी कोई नहीं है, चलो ये भी उनको दे देंगे। तो थैंक यू वेरी मच, बहुत शुक्रिया। हाँ, लास्ट तो प्रोफेसर अक्षर हैज डन अ वंडरफुल जॉब। मैं आया हूँ तो वो गार्ड ने कहा कि आप आई प्रेजेंटेशन में आए हैं मैनेजर की, तो वेल डन सर, आपने बड़ा
At the end, as President OSP Lahore, I would like to thank everybody for attending the session, especially Professor Arshad for organizing a very well organized presentations and all the organization of the event, and the participants were very nicely done. Just with the coming up events for OSP Lahore, we are having the annual Lahore Ophthalmo from the 7th to 8th December. So it's an Afro-Asian Congress of Ophthalmology. So everybody is requested to participate. Thank you, Dr. Samra. Yes, thank you. आप शुरू से बैठी हुई हैं नहीं वेल नहीं ठीक है आप खाना खा के जाएं जरूर अच्छा अच्छा ठीक है उनको भी खाने में बुला लें चले thank you very much. So I would actively ask everyone to participate in the meeting, not as an audience, but as a participant. All of you are making such a good presentation, so you should submit your papers. I think the last date for submission is already finished, but you should always try to sort of attend the meeting. We'll have about 50, we are planning to have about 50 international speakers. So please, in your very busy schedule, do make time to attend meetings. अक्सर यही होता है कि हमने इतनी presentations इकट्ठी की होती है और hall खाली पड़े होते हैं. सिर्फ presenter नहीं चाहिए होते. We need audience as well to listen. And it's a very once a lifetime जो आप बाहर नहीं जा सकते. You have a time to go and listen to experts from internationally to all around. So we have international speakers coming in medical education, vitreoretina, oculoplastics, glaucoma, pediatrics. So all subspecialty. So we hope to have it as a great event. The next clinical meeting is going to be held at CMH on 15th October. So we'll ask everyone to come here and join us over there. In the end, Jisani Surgical is not here, but we'd like to thank them for their hosting the event. And now I'd like to request everybody for lunch, which is arranged. कितनी बार बतानी है? ठीक है. Thank you very much. Mateen साहब भी आया University of Lahore से. Thank you very much. Good to see you. चले. Thank you very much everyone.